Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
All right. Good afternoon, good morning, good evening, wherever you're coming, whatever time zone you're coming into us from. Welcome to the next episode of the Dusty Muffins. Today, we're going to talk about the Women's Health Initiative. We're going to unpack that WHI study. We're going to talk about the myths, the misinterpretations, and what women really need to know. I'm Dr. Christine Hartcrest. I'm a board-certified women's health nurse practitioner, and I'm a menopause certified practitioner.
I'm Aoife O'Sullivan. I'm a board-certified family physician and a Menopause Society certified practitioner here in Portland, Oregon.
Hi, everyone. I'm Dr. Rebbecca Hurdle. I'm a board-certified osteopathic family medicine physician and a certified menopause practitioner in Erie, Pennsylvania.
What are we talking about today, Christine?
Oh, we're talking about the Women's Health Initiative
Our
study.
favorite subject.
The things that abolished all things.
Get ready for some rage.
I know.
Get ready for the perimenopause rage.
Oh my goodness. Absolutely.
Oh man.
Where shall we
really
start? Where shall we start?
Oh my goodness. Well, you know, Aoife, we could start at what it is, right? What it was, right?
Yeah.
Yeah.
Will I go?
Yeah, we love
your rendition of it's beautiful.
Let my rant begin.
Let it begin.
So estrogen was discovered back in the 20s and 30s, and at some point they discovered that it was very helpful for women who were going through the menopause transition where their estrogen levels were going up and down and they were having a lot of symptoms. And then during the 60s and 70s, they noticed that the incidence of uterine cancer was increasing with these women who were just taking estrogen alone. And they realized that if you were giving a woman who had a uterus hormones, you had to give her progesterone as well, because estrogen is wonderful at making things flourish and grow and being nice and spongy and happy. And progesterone can help in the uterus do the opposite. It can keep the lining nice and thin. And therefore, if you're on estrogen and progesterone and you have a uterus, that your risk of uterine cancer then does not change from your baseline. And so they started to give women both hormones. And what they were noticing was that women who were on hormones going through the menopause and for years afterwards were not having heart attacks and strokes. They weren't developing diabetes. They weren't getting dementia at the same rate that men of the same age were. And we even know from calculators that we have now, risk calculators, where you put in your blood pressure and your age and your gender and race, that when you're a woman, if you go in and you put 49 in the calculator, it says your risk of having a heart attack or stroke in the next 10 years is 1%. And if you put in 51 instead of 49, it goes up to 4%. And that's purely based on menopause. They know what happens to our bodies during menopause and how that really increases our risk of cardiovascular disease. And so we had a lot of observational studies on these women showing that they had massively decreased incidence of heart attack and stroke. And they thought, you know what we don't have though? We don't have any information about giving older women who've already laid down the foundation to have heart attacks and strokes. We haven't seen what giving them hormones does. Because sometimes in medicine, if you give somebody a medicine for some condition they have that's quite mild, it's very effective. But if you give that medicine to someone who has that disease or condition very severely, you can get really good results from it. And so they were wondering, if they gave older women hormones who were at risk of heart disease and stroke, would that actually really benefit them? And I think we found out the answer. But what they decided to do was, so this was a randomized control study. So often, oncologists and doctors, they don't know very much about this study, but they've heard little sound bites and they know it's a randomized control study, which is our gold standard study. But what they don't know, it was a randomized control study for cardiovascular disease. Not for breast cancer, to see what hormones did with breast cancer. And so they treat it as a gold standard study for what hormones and breast cancer, how they're connected or not connected. But actually that's just not good. When you have information like that from a randomized control study and it's not what the primary outcome, what you were looking at, the primary outcome, then really the best you can say is that it's observational data. So you observe that this happened during the study. So not gold standard information.
It wasn't a little study either.
No.
I mean, there were 27,000 women that were between the ages of 80 and 79. So this isn't by any means a little study. And if I remember correctly, it's like billions of dollars. So, through the NIH, like they put a whole lot of money into it. And then separated the women into two arms. There were 16,000 women who had a uterus present and another 10,000 who didn't have a uterus present. So the women who had a uterus were put on conjugated equine estrogen or Premarin and medroxyprogesterone, both synthetic hormones. And the women who did not have a uterus were given conjugated equine estrogen only. But the thing about it was that the average age for these women were 63, and they weren't healthy people. They had hypertension. 45% of them were past or current smokers. And, somewhere upward, like 70% were either considered overweight or obese, 35% overweight and 34% obese. So these were women that probably, I mean, if they benefited, great, but they were already at high risk for cardiovascular disease.
Yeah. And then between the ages of 50 and 79, I know that's what you meant, but I think you said 80 and 79.
Oh, I meant 50 and 79.
I know you did.
That's our perimenopause.
Just to clarify for listeners.
I didn't even know I said that. Thank you.
It was such a goal, it sounded so good. I was like, oh yeah.
Nope.
Seemingly, it cost like $1 billion, this study, and they were repeatedly dragged in front of Congress to explain where this money was going and was it worth it. And there's an interview with Dr. Robert Langer. Dr. Louise Newson does it actually. It's a couple of years old, 2 or 3 years old, but he tells a very interesting story. He was one of the lead investigators in the Women's Health Initiative study. And so they were all called in for their meeting, which happened every 6 months. And they all thought they were going to have a little snooze through it. And instead they were met by a small group who said, you know what? We have stopped the study. We're stopping the study because we see a connection between women who are taking the estrogen and progestin and an increased incidence of breast cancer. We've already written articles for the paper and are releasing it to the media. And we've put together this article for the biggest medical journal at the time, really. And so the investigators were really thrown by that. And there were a lot of arguments. And Dr. Langer he said, if you do this, you can't put that genie back in the bottle. Women's healthcare will not recover from this. And they went ahead and did it. And when you look at the numbers, they were actually not statistically significant. So in science and medicine, if you're doing a study and something is not statistically significant, it goes in the trash can and you move forward. And they did all of this with numbers that were not statistically significant. So just absolutely horrendous. And then 2 years later, stopped this part of the study where women were just using estrogen alone, saying that there was an increased incidence of stroke. And what you see is the incidence of breast cancer in that arm going down and almost approaching statistical significance. So there was some question as to, did they do that because it would be very difficult to explain why hormones in one arm were decreasing your risk of cancer and seemingly in the other arm were increasing your risk of cancer.
Yeah, I have this I call it an artifact. So I don't know if you can see this, but this is from 2002. And so I was practicing in July of 2002. This came out in August of 2002 from the pharmaceutical company. And this was, I don't know why I saved it all these years. Who knew I was going to be doing this work? But it says, understanding the results of the combination HRT component. And I think I have another one somewhere on estrogen only. And so I thought this was interesting because I've heard some different numbers, but out of 10,000 women, the women who were taking placebo compared to the women who were taking hormone therapy, there were 8 more women with breast cancer, 7 more women with heart attacks, 8 more women with strokes, 18 more women with blood clots, 6 fewer women with colorectal cancer, and 5 fewer women with hip fractures. And, what I thought was really interesting is that this, and we'll talk about this, it says on here, because of the potential increased risk of heart attack, stroke, breast cancer, blood clots, use of combined therapies should be limited to the shortest duration consistent with treatment goals and risks for the individual women, and should be discussed with your physician regularly, which is kind of funny because this was for the provider, not the patient. But I just thought that was just interesting that I had that historical artifact. I mean, maybe it'll be worth something one day.
Do you know what the World Health Organization classifies as rare? Something that's very rare?
No, do tell.
Less than 10 per 10,000.
Oh, I did
So
not
there you
know
go.
that. So almost everything on here is rare except maybe the blood clots.
And everything on there, Dr. Lauren Stryker is an OBGYN, and she also has an amazing podcast that you can learn so much from. And she did a great breakdown on this. But she was saying, I don't even remember where I was going with that.
That perimenopause number 2 just happened right in front of your eyes.
Where was I going with that?
Brain fog it's gone. In outer space.
It's gone.
Was it about the blood clots? Were you going to talk about that?
I don't know. Oh, I know what it was. She was saying that, they present it as so terrifying and scary, but actually 97.5% of the women in that arm, the estrogen and progestin arm, had absolutely no problems. So we're talking about a tiny percentage of women who had a problem. Now you give oral estrogen and oral synthetic progestin to older women, and we know both of those can increase your risk of blood clot and stroke. And you give them both to women who are in their late 70s. And then you say, oh dear, we have a terrible problem. People are having blood clot and stroke. I mean, I was in med school at that stage, and I could have told you giving women oral estrogen and synthetic progesterone would give them a blood clot or a stroke. How was that surprising?
It made no sense to me at all.
Yeah, because you figure by the time you're in your 60s or 70s, you've had a couple decades of whatever it is that you've defined as your life habits, right? And so if you already have things like high blood pressure, high cholesterol, and then you've been without estrogen and the arteries get a little, they vasoconstrict and then the lining gets sticky. And so you can, just by your lifestyle and genetics, environment, all the things, then have plaques. And then we give you estrogen, we open everything up. I mean, it's not that surprising that, the plaque's going to fly and you could potentially have a bad outcome if you have plaques in there. And then you add smoking, which we already know increased your risk of cardiovascular disease. So it's like, who designed this study and thought this was a good idea? And why wasn't there a pharmacist to talk about the pharmacokinetics, which we never talked about, giving, like back then, we never talked about how estrogen is an anti-inflammatory and it decreases your blood pressure or decrease your risk of diabetes. So, I mean, I don't know, so many flaws, right?
Yeah, I think about that too, because I was just, like I said, just starting medical school at that point when this came out. And so it was just such a huge hole in my career. And it was just, you just don't do it. That's what we were taught. You just don't do it. And you're right. I don't remember any of those pharmacokinetics. And, to even be able to then know what the benefits could have been, it just was like, that's what everyone told me. That's what I was taught. And so I moved along and, told all these women, absolutely not. Or if it is, it's the lowest amount for the shortest amount of time. And you need to get off of that. I mean, I took women off of it, at some points and different points. And so, it was just a study that was so good in so many different ways too. We did learn so much from it. We really did. And I was educating, a patient on that earlier this week that said, listen, what did we find from it? Well, we found that's where that 10-year, that timing hypothesis comes from for the most part, right? Not that there aren't outliers to that, but we know that within those 10 years of your last menstrual cycle, I always call it, you get the most bang for your buck. Does that mean that 1 year after you start your periods, if you're 1 year over that 10-year, no, 12 years, 15 years, I mean, it's always a risk benefit discussion with your patients, whether or not you start them on, something outside that 10-year window, and that's individualized care. But dang it, we did learn some really cool stuff though, that, let's not stop. So these women coming in and talking to us about, what do I need to do? Although not indicated for primary prevention of those things, it's still, a good conversation to say, hey, you might be having some hot flashes and night sweats. Let's go over with the FDA approval. But there's so many things off label. We can still get you on menopause hormone treatment that will benefit you in the long run. So we did learn some good things, I think, from that study. But boy, there's such a stigma that still to this day, people get harassed by their friends, their family, you're going to die. This is what women are told. You're going to die if you go on hormone treatment. And I think it's absurd.
And if you scratch the surface at all, if you just ask one more question, where did you hear that? Tell me about that study. When was it? What happened? No one can answer any further questions. It's literally just baked into you that hormones cause breast cancer. And there's no deeper information than that. It's so wild. I've never come across anything like it.
And I believe that word from clinicians, I just don't believe in it. Well, let me tell you one little damn thing here. I just don't believe in it is not how we are taught to be clinicians and providers. We use evidence-based medicine. We use shared decision making. So that means that when you go into your clinician and you talk about these things, that he or she should show you the evidence, and you then sit together and you talk about things together and come up with a decision. This, I don't believe in it, is the biggest amount of bullshit I've ever heard.
Do you think anyone has ever said to a man, I don't believe in erectile dysfunction?
No.
What? Could you? Sorry, Charlie.
I don't believe in it.
And you can get all the drugs to fix all the penis problems in the world. They are all available, covered by insurance. Slap them on, take a pill, do a penile implant.
And we're going to digress with, I'm not sure what vaginas you're sticking those penises in, because if they don't have hormones, they're not going anywhere. So, yes, to that. So this WHI study did a number, and not only, I think the other thing is that, so we all in their amazing knowledge would have thought that the breast cancer risk would have declined. But ladies, tell me what happened to that breast cancer risk over time, over the last 22 years. Did it decline? Stop getting everybody off their hormones?
No.
So it did not. It's gone up every single year, 0.5%. So the authors of the Women's Health Initiative, the ones that were quite involved in bringing it to its knees, actually released an abstract this past year. I feel like finally putting a nail in the coffin and saying they looked at all the randomized control trials on breast cancer and estrogen. And this is the final word. Breast cancer decreases by 23% relative risk if you are on estrogen alone. So
say that one more time. Say that one more time.
Your risk of breast cancer decreases by a relative risk of 23% when you use estrogen alone. So what we know is the risk of breast cancer is firmly connected to the progestin, which is a synthetic progesterone that you use. And so, that really changes everything.
And the thing about that whole study was, in order to go into the study, you couldn't have any symptoms. Otherwise, you would know what arm you were in, right? And, we were kind of, hammering a little bit, I was, about, the older women, the average 63, which, I'm not that far away from. So, but isn't it amazing how, like our first grade teacher was probably really, really ancient, but she's probably younger than we are today. But anyway, we digress on that. But, the women between 50 and 59, which are the majority of the women starting on hormone therapy, they did absolutely fine. They didn't show all of the increased risks. And so it's like, putting the wrong people on the medication without, making sure that they were a good fit, ruined it for all the people who were actually symptomatic, the ones not in the study. And, back in 2002, there were 90 million women on hormone therapy. And today, if we do the 50 million, that are in menopause, let's just say today over the age of 50, only 1.8% are on hormone therapy. I mean, like, it just knocked the block.
It boggles my mind.
But yet 61 million women were on antidepressants in 2015. That makes you go,
right. Right. And all the libidos that are declined with that amount of antidepressant therapy, let me tell you.
I want to break that down because that's really important, Christine. So when they looked at the numbers from the Women's Health Initiative study, the women between the ages of 50 and 59 had no negative outcomes. They did great. The women between the ages of 60 and 69 did great. It was called a null benefit. Risks, benefits, all equal. And the women who were between the ages of 70 and 79, which in general, we don't usually start hormones in that age, but, a lot of women are coming to us now in their 70s.
Right? They've got osteopenia.
The boomers are pissed. They want in.
And their cardiac risk is low.
Yeah. So you did see they were the small percentage of women who you saw the increased risk of heart attack and stroke in. And you saw it over the first year of treatment. And then it went back down to their regular baseline risk. So there seems to be an increased risk in that first year. And then it goes back down. And those were the older hormones that we don't use anymore. That synthetic progestin is very inflammatory. It seems to delete out the positive effect that estrogen has. And so that's why we tend not to use it anymore. In some women, we have to use a synthetic progestin because they aren't able to tolerate micronized progesterone. But in general, we'll use micronized progesterone or the Mirena IUD.
Oral preparations too, right?
Yeah.
It's, like oral preparations, which go through the liver and can affect the clotting factors and first pass metabolism and all of that. Whereas your transdermal preparations, don't do that. So that makes a difference as well.
We're going to have a whole episode on myths, aren't we? Where we'll cover that.
Yeah.
I can't wait for that.
The goodies, all the goodies.
All the goodies. Exactly.
I think
Yeah.
one thing is about, the bone health. So,
Mhm.
we know from that study how protective estrogen is for prevention of osteoporosis. And one of the things that drives me absolutely crazy is when providers actually will order a bone density study before the age of 65. I'm like, yay! And then it shows osteopenia, and then there's no conversation about hormone therapy. They talked about vitamin D, maybe vitamin K2, calcium, strength training, all awesomely blossom. But without estrogen, you're just going to continue to
Yeah.
lose. And then I have seen patients who've had a bone density study every 2 years because the provider's really good at that. And then I've watched the bones fall off the cliff, and no one ever had a conversation with them about putting them on hormone therapy.
No, they don't know what to do. They don't have the education, I think, to do that, right? To just be like, oh, hey, guess what? We can put you on some estrogen. Here's your risk, your benefits. It's going to really help your bones.
Yeah, but hormone therapy is FDA approved for
I
treatment of
don't think they know it. Did you know that?
No.
vaginal dryness
I didn't
and
know it.
of osteoporosis. And
No,
there's
before I got in,
of it.
I know before I got into menopause care, I didn't know that I could just throw an estrogen patch on their ass and they'd be good to go for their bones.
Yeah,
You know
but
what I mean?
even in the last couple of years, like I see patients.
Yeah,
I mean,
I know.
it
But I think we
blows
live in a
my
space.
mind.
We still live in this space. If you don't have I think in their brain, it's hot flashes and night sweats. I don't even think it's genital urinary syndrome of menopause, which is also an FDA approval for hormone treatment, right? They're just not thinking that. And that's, this is also for providers, not just, our beautiful women out there who aren't providers, but those that do, that may listen to this and learn and just be like, okay, I need to go take some courses. And this needs to get into medical training. This needs to get into medical training, and, maybe that'll be one of our podcasts where we'll get some wonderful women who are in their medical training currently, and we'll ask them how their training is. But
I saw a patient yesterday, and she's having some right upper quadrant pain. She thinks she's got non-alcoholic fatty liver disease. And I said to her, my favorite line when I was in GYN, you should see your primary care provider about that. And so I asked her, I said, have you made an appointment with your primary care provider? She's like, I can't. I'm like, what do you mean you can't? If she sees that I'm on hormone therapy, she's going to fire me as a patient. She's in her 30s,
terrible.
and she doesn't know anything about hormone therapy. But this is even more terrible. She's like, I live in a small community and there are not a lot of options. And she's like, I don't know what I'm going to do, because she made me go off of it before and I was miserable until you let me go back on it. She went to pellets, because that's what happens. Providers,
Right.
you tell them no, they go to where they'll get it, which is pellet providers will
Go to the
put you in a
underground.
pellet for $700 every 3 months. And so we got her off pellets, and now she's on, really low dose, and she's petrified to go to the doctor. And I said, look, she goes, she's really great. And I said, no, she's not, because you're afraid. And so now I got to help her get a new primary care. But really, I want to pick up the phone and give her primary care some education, because that's what's happening to women. They're afraid to go tell their dirty little secret. They're on hormone therapy. That is terrible. Sorry. Yep. That was my rant from yesterday. That just made me I felt so sad for her and frustrated.
Yeah, it's horrendous.
Yeah. I think that we kind of really hit just a really nice topic in a way. I'm hoping that everyone could understand about the WHI and where the breast cancer scare came from, that hormone therapy is safe if you're perimenopause, menopause, and you have to have a risk benefit discussion with your provider. They should be able to talk to you about those risks and just really explain, even literally in 5 minutes, you can explain the guts of the WHI, I think, to your patients and where that came from. That there are risks, benefits. Most women, the benefits outweigh the risk. I mean, I'm going to say that I don't have any problem saying that. I think most women, the benefits outweigh the risks,
What are the risks? What are the risks? This is what gets me. Like, what are the
I
risks?
know,
What risks are
And
you
then there's
talking about?
The risk from
yeah,
the hormones
yeah.
that you've had all of your life until
Yeah.
you
Your
didn't,
whole
and you
life,
did just
your whole
fine with
life,
it.
you've
Yeah.
had them, and then all of a sudden, now it's risky, right?
Right? We're giving you back the same thing that you were making.
You were okay with it at the level of
Yes,
1700 when you were pregnant,
yes.
but you're not
When
going to
you
be
were
okay with a level of
with it,
60. Okay. All right. I
Right.
don't I don't see
Exactly.
the sense behind that. Okay.
yes, yeah, and I think we kind of went over, these great insights and how the WHO was misinterpreted, that was and caused all of this fear. Although I think there's still so much of that. So we're all working on that. That again, we talked about that it can be very safely prescribed, when needed, and that we encourage, everyone to really seek out a certified menopause specialist to talk about this, because, you're really not going to get it probably from anywhere else. Hopefully, at the very least, they're going to tell you, find yourself a good menopause practitioner.
Mhm.
Yeah. Key
Fingers
takeaways,
crossed.
I would say the 10-year window, what we learned from the Women's Health Initiative study and some studies that came after that, that giving hormones to women when they're in those first 10 years after their last period is very safe.
Mm-hmm.
Those older hormones that seem to cause the problem in much older women, we don't tend to use those anymore. So we think the hormones that we use now are even more safe than what we were using 20 years ago. We just need studies to prove it. But what we see in clinic every day, because a lot of us start much older women on hormones, is that it's very, very safe. We also didn't mention for women who are in premature ovarian insufficiency, POI, that's when you go into menopause before the age of 40, or early menopause, which is when you go into menopause before the age of 45. Hormones are standard of care. Because if you are in POI or early menopause, the guidelines say you should be on hormone replacement therapy at least until the age of natural menopause, which in America is about 51 and a half years of age. So
And
that's
much higher levels of estrogen.
Yeah. And also, and that when we take women's ovaries out for any reason and we don't give them hormones, we see this accelerated cardiovascular disease. And so that shouldn't even be an argument with your clinician. I mean, that is standard of care.
Right. Yes, if they don't put you on hormones, you need to find someone else.
Yes, because your health is really at risk. Yes.
Bones, brain, heart.
Yeah. And again, was I taught in any of my training about premature ovarian insufficiency, early menopause, and that those women are supposed to be put on hormones? I was not. So I can't blame any other clinician that doesn't know that either. We weren't taught it, but the information is out there. The Menopause Society has guidelines on this. So get your hands on them and bring them to your clinician. I would say the second takeaway is that we have different types of hormones, which we'll get into in another episode. Some go through the skin and some go through the mouth. And third would be estrogen. I think we can put the final nail in the coffin. Does not increase your risk of breast cancer. Any other takeaway tips or key takeaways?
I think what I would say, and I'm probably always going to be the one that wants to battle. I like to battle sometimes. Is that if you're told it causes X or it is bad Y, I would ask, show me that article. Because there have been follow-on studies out 18 years. And what they concluded was that the women that were on hormone therapy, whether it was the combined synthetic hormones or just the estrogen alone, they didn't die of anything sooner, different, more frequent, nothing compared to women who are on no hormone therapy.
Yeah, I don't have any other further ones. We talked about resources like the North American Menopause Society, other consultation services, our websites, our Instagrams, have a lot of information on there. Reach out to us, ask us questions. We're, always willing to at least give you a direction if needed, so I think it's just really important to make sure why it's important to then understand that is old. It was incorrect data to begin with, but that is not the standard of care.
Fabulous. Well, thank you, ladies. Thank you, listeners. We enjoyed spending this time with you. We hope you laughed a little. We hope you learned a lot. And stay tuned for our next episode where we're going to talk about hormone therapy, myths and menopause myths. And so all things myth-like. Come join us next time. Have a good day. Bye-bye. Thanks for tuning into the Dusty Muffins. We hope you laughed, learned, and felt a little more empowered on your menopause journey. Don't forget to subscribe, share, and leave a review to help us spread this sisterhood and strength. Got questions or topics you want us to cover? Reach out. We're here for you. Until next time, keep thriving, keep laughing, and remember, you're never alone on this wild ride. See you next time on the Dusty Muffins.